Hello, everybody. Thank you for joining us here today. My name is Fabiana Bacchini. I'm the Executive Director of the Canadian Premature Babies Foundation. For the last 4 months, we've been doing Facebook Live, interviewing researchers, lactation consultants, healthcare professionals in general, and NICU parents to share their experiences, their knowledge, their expertise in anything related to the premature world. We started doing this to talk about the pandemic and the COVID-19, but all education sessions in hospitals have been canceled since March. So we decided to do virtual education sessions for families who are watching us from home or hospitals at this time. So today we're going to talk about breast milk. This is something that we talk about a lot, so we know how important it is for babies who are born preterm. And today I have here with me from Saskatchewan, Natalie Millar. She has been a clinical dietitian for 15 years with 10 years dedicated to the Regina General Hospital NICU. She's a certified lactation consultant, co-chair of the Donor Human Milk Committee of Saskatchewan and coordinator of the Regina General Hospital's milk drop for NorthernStar Mother's Milk Bank Milk. According to her 2 young kids, Natalie's job is to steal milk from ladies and feed it to all the teeny babies. Natalie, welcome. Thank you so much for joining us here today.
Thank you for having me. This is my first ever Zoom call, my first ever live Facebook chat. So this is very exciting. Thanks for having me.
That is wonderful. It feels like this is our new world. I was so grateful to, we met in February in Banff. You did a wonderful talk and now you're here. This is our new reality right now.
Yes, thank you.
So let's start by talking, what is the importance of breast milk for preterm babies? But first I wanted to tell us, what is breast milk? Because we always talk about this is the most important thing for babies in general. It is more than just food, it's medicine for preterm babies. What is the breast milk and how important it is?
You took the words right out of my mouth when you said breast milk is just, it's not just food, but it's medicine. And I hope NICUs are saying that to their parents, and I'm sure parents have heard that before. And so breast milk provides very important nutrition for the preterm babies, provides excellent hydration, but that medicine piece of that, what you had just said, talks about the important health benefits breast milk gives to baby. It provides bioactive factors. Bioactive factors, or saying something's biologically active, which breast milk is just a fancy way of saying that breast milk provides health factors to the baby. So one thing that breast milk gives are growth factors. So we know preterm babies, they come out and all their vital systems are still very immature. They still have a lot of growing and maturing to do. But there are growth factors in breast milk that help the digestive tract to grow and develop. There are growth factors that help the tiny little vessels in the back of a baby's eyes to grow and mature. So that breast milk really helps the baby to grow and mature in the same way that the factors from amniotic fluid when the baby was in utero does. Of course, there are important immunological factors that help prevent infections. And we know that preterm babies are at very high risk of a very devastating disease called necrotizing enterocolitis. I'm sure most of your NICU families will be familiar with this, especially if they've had a very low birth weight baby in the NICU. And the acronym for this is NEC, and NEC is really an infection of the intestines. And preterm babies, for a variety of reasons, are at very high risk of developing NEC. But we know that breast milk helps to protect babies from developing NEC. And so this is why there's such a push for moms to pump and provide their breast milk, or when we can't get the breast milk from the mom, a standard of care is really to use donor human milk because it protects the babies. And it does it in a variety of different ways. So there are some components in breast milk, for example, that are called macrophages, and their job is literally to eat bacteria up. There are some components, there's one called lactoferrin, and what it does is it binds up all extra floating iron around the baby's system. And there are some bacteria that love iron for food. And so the lactoferrin binds up the iron so that the bacteria can't get the iron and grow. There are factors that actually will destroy the cells of bacteria and viruses. There are components, there's sugars in breast milk called human milk oligosaccharides, and they can act as good food for good bacteria, so the good bacteria grows, but then they also displace bad bacteria, so they take up space, so the bad bacteria can't lodge themselves in the cells of the baby, particularly the gut, for example, and thus reducing the risk of NEC for babies. So breast milk is important for all infants, but especially preterm babies, because it supports growth and development and helps to protect them against disease.
So do we also know the long-term benefits for premature babies who receive breast milk?
In terms of neurodevelopment and brain development, absolutely. Studies have shown that when babies can get breast milk early on and for as long as possible, yeah, they'll have better long-term outcomes. And certainly for preterm babies, and part of that is largely to do as well by just avoiding these adverse outcomes that breast milk can help to prevent.
So we also know, like when we're in the NICU, we also hear that our breast milk has to be fortified in the NICU. Why is that? If the breast milk has all of that you just mentioned and is the best for babies, why does it need to be fortified?
That's a really good question. It's a question I get often because we talk to parents about how breast milk is so full of the nutrients that a preterm baby needs. It has everything the baby needs and it's so easily absorbed and digested. And then, you know, in the next breath, we're adding fortifiers to the breast milk to boost both the macronutrients, so macronutrients are protein, carbohydrate, and fat, and the micronutrients, which are vitamins and minerals. But why do we need to do that? And there's a two-part answer to that. So one is, compared to a full-term baby, a preterm baby has very, very high nutrient need. So the younger the baby is in gestational age, the smaller they are, the higher their nutrition needs are going to be. So for example, a very low birth weight baby, we try to target, to be a little technical here, 4 grams of protein per kilogram per day. Now, if we were to do that for an adult, for example, like a 200-pound guy, he would need to eat 5 8-ounce steaks a day to get that same amount of protein. It's insane how much preterm babies need. It's because when they're on the inside during that 3rd trimester, that's a period of very quick growth. And it's a time where they build up all their nutrient stores for best growth and development for when they're born. So for example, by the time a baby has reached 34 weeks gestational age, they've built up 80% of their calcium stores for healthy bone development. But if they come too early, they miss out on that really important time to really build up those nutrient stores for best growth and development. The other issue is that a preemie baby's stomach is tiny. It's so small, and we could never feed them enough breast milk to meet their high needs without causing throwing up, feeding intolerance. There's just no room for it. So compared to the typical volumes that we know babies can handle in the NICU, to meet the high energy needs, we'd have to probably give about 30% more breast milk volume. To meet their protein needs, we'd have to double, sometimes even triple the volume of the breast milk that they could handle. Same thing for certain minerals. We'd have to give, you know, almost triple the amount of volume of breast milk to meet their high needs. So they have high needs and teeny tiny tummies. And so what we do is we work with the volumes that work with the babies. And in order to get the high nutrition that they need, we add fortifiers to it. Now, different NICUs will have different protocols, different guidelines. There's different options of different types of fortifiers, and different NICUs will use different brands even. They'll start at different times. They'll advance it differently. So it really depends on your NICU. So have that conversation with the team, pull the dietitian aside and have a chat about what the NICU's guideline is and how they plan to fortify.
That is great information, because this is one question we always ask in the NICU, but why do we need to do that? But your explanation was very clear and very timely for families who are in the NICU. But lately we've been hearing a lot about exclusive human milk diet. What is it?
An exclusive human milk diet is where we can add a fortifier that comes from donated human milk. So typical traditional fortifiers, they've either come in a powder form or even a liquid form, and they are made from a lab, right? Made from the formula companies, and the protein in there is a cow's milk-based protein. With an exclusive human milk diet, the fortifier actually comes from pasteurized donor human milk. And this human milk has been concentrated. So basically, in a most simplistic way to describe it, the water's been taken out of this donated human milk, and what's left behind is a really rich, high in calorie, high protein, vitamin, mineral type fortifier. A little bit of minerals are added, but then they can take that concentrated, that nutrient dense pasteurized donor human milk and then add it to a base diet of either mom's milk, or maybe that baby's getting pasteurized donor human milk, or maybe a combination of mom and donor milk, so that the baby in essence has a diet that's 100% human milk.
Okay, so you have some experience with that. Can you share with us what your experience has been in your center?
Sure. We've been fortunate enough to have the option to use a human milk diet since 2010, actually 10 years ago was the first time we used it. And actually back in 2010, this fortifier, which is made in the United States, wasn't approved for use in Health Canada. But we had a family here who was really passionate about using human milk for their very preterm baby in the NICU. And they were really the catalyst to have it approved for use in Canada, and the real reason why we started using it here. So once we put the request into Health Canada with the advocacy from that set of parents, it was quickly approved, and we used it and had great success with the baby, tolerated it well. But in 2010, there wasn't a lot of research on using it. I mean, theoretically, it makes sense, right? You're giving baby 100% human milk. Of course, that makes sense. There wasn't a lot of research, and in combination with the fact that it had a very high upfront cost, we really didn't adopt it as a standard of care till a few years after that. So we didn't use it again until 2015, when we had a couple of babies who unfortunately developed necrotizing enterocolitis. And when we got to the point where we could refeed these babies, we thought, you know, we want to try the human milk fortifier and see how they do. And they did extremely well. And their tolerance to the feed advancement and this diet was not what we had traditionally seen when we tried to refeed babies with NEC. And so we met as a team, and we talked about maybe adopting it. And at the time, most of the research, all of the research at that time really came out of the United States, and they were using it for all babies less than 1,250 grams. So we did a brief cost analysis, and we already had fairly low NEC rates in Regina, and we came to the conclusion that, you know, based on the cost, the fact that we have low NEC, it just wouldn't be cost effective to use it for less than 1,250. But we thought, you know, we had great success with these few babies that did well with it. Let's adopt it. Let's make our own criteria for use. We don't have to follow what's being done in the United States. And we decided to use it for babies less than 750 grams. So we started that 2014, 2015. And just since then, you know, every year we've had more and more babies. And as, you know, we really got used to using the diet and more comfortable with it. And anecdotally, we were feeling that babies were doing better with it. They tolerated it better. We expanded our criteria. And now our criteria is we use the human milk fortifier, human milk based one. We use it for all babies less than or equal to 1,000 grams. We use it for babies less than 28 weeks. And our NICU family to the north in Saskatchewan, they started using it in 2016. Their criteria is a bit different. We are working together to sort of align our protocol, but they've been using it, and their experience has been very good as well. One of their neonatologists, Dr. Samadi, who actually gave me permission in Banff to share her early preliminary findings, what she was finding is that there was a statistically significant reduction in the number of NPO days. So there's days where babies aren't allowed to eat because they think they have a feeding intolerance. Mm-hmm. The number of days they receive TPN, which is that intravenous nutrition, and the number of abdominal x-rays the babies were exposed to because they worried the baby had NEC or a feeding intolerance. So they're having good success using it in Saskatchewan as well. We did a retrospective chart review because we wanted to really assess our outcomes of use. And our numbers are quite small. So of course, we're not going to show a statistically significant difference in sort of the major adverse events that can sometimes happen to preterm babies, like necrotizing enterocolitis or chronic lung disease. But what we have been able to show so far is that our babies who receive an exclusive human milk diet, they actually leave the hospital earlier than babies who didn't receive it. And that's good news for everybody, good news for the families. It's certainly good for our, you know, our finance department as well too. So we've been able to show a benefit that way. We are going to look a little further. We want to see if we've noticed a difference in abdominal x-rays or TPN days as well in terms of that feed intolerance. Anecdotally, of course, our team would say the babies tolerate it excellent and we've had no problems with feed intolerance, but we'd like to go back in the charts and actually confirm what we think we're seeing.
That is great news. I think it feels very positive and something like a light in the NICUs for families. Do we know, are we going to follow those babies like a little bit longer term, or just the NICU to see how well they do in the first few years?
That is on our to-do list. We would love to be able to do that. It is definitely on the to-do list. There are some studies coming out of the United States showing long-term neurodevelopmental benefits. So there's some research already being done on that. We would love to be able to contribute to that emerging body of knowledge as well. So we're going to focus on what we've been doing right now. And once we get our heads wrapped around that, yes, that will be a next step for us, because we'll have a good chunk of Canadian data to work with, because we've been using it since 2014.
Oh, that would be great. And please, you let us know. And I would love to have you back here to talk about that and the more findings and more evidence that is coming out for sure.
Yeah.
So Natalie, but I want to go back to the NICU and the breast milk from moms. Like, let's talk about pumping, because we know pumping is very hard work for moms. And this is not how we imagine our lives to be, that we have to pump 8 times a day for so many hours a day to feed the baby. But knowing all the benefits, a lot of moms really put a lot of effort in pumping. My first question to you is, how early should the mom start pumping after delivery?
Well, short answer, what we tell moms here is we try to do it within 6 hours of delivery. A little bit of a longer answer, I think there's a lot of families and even staff that feel the pressure to do it within 1 hour of delivery. And I think that comes partly from research has told us that the earlier you can initiate breastfeeding or pumping, the better success you'll have at getting adequate supply and even long-term breastfeeding. I'm sure a lot of families have heard of the BFI, or the Baby Friendly Initiative, and they have 10 steps to promote, support, and protect breastfeeding. And one of the recommendations for the hospital is, as soon as a baby is born, to put it skin to skin with the mom within that first half hour, try to establish a latch and breastfeeding within that first hour. But that BFI really applies to full-term, healthy babies, not an unstable preterm baby, where that baby is whisked away from the mom and they're separated right from the moment that baby is born. What we do know, though, is research is showing that if we can get moms either hand expressing or pumping within the 6 hours, they still can get adequate volume, and it can help to maintain lactation longer term. And in fact, that original BFI, the 10 steps, has been adapted, and there is a neo BFI that applies to preterm babies and unstable preterm babies. And the goal is to do it within 6 hours instead of that first hour. That's more realistic, and it's borne out in the research. And even if it has been longer than 6 hours, we still need to encourage moms, support moms. And I think if the bedside staff are aware that it has been longer than sort of that recommended 6-hour window, that family might need a little bit more hands-on, more regular follow-up, more check-ins, just to make sure that they're feeling supported and getting what they need to successfully pump, and eventually, if their goal is to put baby to breast.
So how, you talk about supporting moms, and we need to get moms pumping or express breast milk the first few hours because of the colostrum. But then we need to support moms to either do that and also to keep going on pumping, and sometimes for many months. How can we support moms in the NICU who are pumping, especially at this time with the pandemic, where it feels that their support person is not always able to be with them in hospital?
Mm-hmm. We wondered this too. We didn't wonder this in the lens of COVID-19, which adds a whole other layer to stress and successfully pumping in the NICU. But last year, we had a group of nutrition students. We had 3 nutrition students who put together a survey for our NICU parents, wanting to know this exact question. how can we better support you for early pumping and pumping maintenance in the NICU? So they did a survey. It was really full of open-ended questions. We really just wanted to give families a chance to just share their experiences with pumping in the NICU. What did they like? What didn't they like? What went well? What didn't go well? What would they tell pumping parents? What do they wish they would have said to their healthcare providers? And the students were able to put the answers into different themes. And what stood out the most for us was that parents really wanted early information that was factual and consistent. So early, they wanted to hear about it in their prenatal classes. So 50% of our respondents were first-time moms who didn't have any experience with pumping or breastfeeding, or what does that mean? So early information. Sometimes there are families who know that their baby's going to end up in the NICU. So those early neonatal consults with the neonatologist should include some conversations about how the family plans to feed the baby and information on the importance of breast milk in the NICU and what that will look like for them. Parents wanted consistent information. I don't think this is specific to our hospital, but parents were finding that the information seemed to be different between the mother-baby unit and the staff in the NICU and the staff in labor and delivery. And we've probably all said similar things in different ways, but just that consistency, the same messaging, because it's very confusing. And when you are in the NICU, it's an unexpected birth, trauma, chaos. You just want consistent factual information. And I think a lot of staff are often reluctant to talk to parents early on because they don't want to add stress. They don't want to add that burden because, like you said, it's a lot of work. It's frequency. It's a lot of effort. And so they don't want to add that extra stress. But what our parents were telling us is that early, factual, consistent, and just very gentle encouragement is really what they craved when they were with us. They also really wanted hands-on learning. They wanted not just like, okay, yeah, you go pump, turn up to this setting for 5 minutes, and you turn it down to this setting, and let me know if the shield fits okay. If it doesn't, we'll get you on. They really wanted the hands-on in those early days of pumping. Set me up with the pump, fit me with the proper shield, show me how the knobs and the buttons work. Don't just tell me, walk me through it because I'm tired. and it's confusing, and so much other information is being thrown at them. If someone just hands-on showing them would have helped. And I'm trying to remember, there was another really important suggestion that they had for us. Even just details such as where to buy a home pump, support me to find a pump, what kind should I get at home? I know I can use the one in hospital, but I'm not going to be here every 3 hours to pump. So what can I do at home? So just really practical, hands-on information.
Absolutely. And I can totally agree with that. As my own experience in the ICU when I first delivered, and the nurse brought this hospital grade pump, a double breast, and she showed me step by step. Of course, she had to show me a few times to remember every step. And yes, and what to buy at home, what kind of pump to get at home, because I didn't want to pump one breast at a time. I wanted to do double pumping to save time. And that hands-on information, it really is really important. It's what families keep asking us at the foundation as well. What do they need? How do they get started? And I also believe in the power of education, because we know better. When we know better, we do better, right? Yeah. So, and I think those information pieces are very important. But I also want to share a resource that we have here at the foundation. We create a series of podcasts for pumping moms. So the sessions last exactly 15 minutes, the time of a pumping session. And we have a variety of topics. They're not very medical, but it's a little bit of information, a little bit of education. And you have 4 podcasts on mindfulness, guided exercise to relax while moms are pumping, that have been very popular with our moms. So we are very happy about that.
No, we'll definitely pass it on to our moms and dads in here.
Thank you. Natalie, I want to also ask you about mom's diet, because this is something that moms always ask us, and you also mentioned they ask you all the time, and depends on our cultural background, what our moms tell us to eat or not to eat. How the question is what lactating parents should be eating, and whatever parents eat does influence the breast milk.
Okay. I get this asked all the time, and my answer is eat whatever you want. Absolutely. But of course, as a dietitian, I'm obviously obliged to say things like choosing healthier options when you can, you know, fruit and vegetables, whole grains, lean meat, absolutely. But really, at this point, especially early in the admission, eat whatever you want, whatever's going to stay down, whatever feels good, eating regularly so that you don't get run down or feeling hungry. Um, uh, Eating, not skipping meals is really important. So that's kind of like the, you know, the general vague answer, but people want specifics, right? So more specifically, questions that I've often been asked. One is, do I need to avoid spicy foods? That's because they're worried that having spicy foods will affect the baby and potentially upset the baby, cause some feeding intolerance. And absolutely not. They don't need to avoid spicy foods because while they were pregnant, I'm going to assume most of the moms were eating spicy foods. And what's really neat is the amniotic fluid can actually take on the flavors of the diet. So really, in utero, the baby was potentially tasting that spicy amniotic fluid anyway, and was being exposed to it. So there's no need to avoid spice or strong flavors in the food. And certainly different cultures have different spices, different flavorings. Stick with what you know. Keep eating it. If you've been eating it the whole time, continue to eat it. There was an interesting study that was done. I mean, maybe not the most high quality study, but what they did is they took two groups of moms and they gave one group a garlic supplement, a really stinky, potent smelling garlic supplement, and the other group didn't get one. And what they found was that the group that received the garlic supplement, those babies actually drank higher intake of breast milk. And so they wondered if babies just enjoyed the different taste. They're not too sure why, but it just shows that having strong tasting milk is not going to put a baby off, and if anything, might encourage them to drink more. There's, again, not great research, but there's some studies that have suggested that by eating a varied diet, it can alter the taste of the breast milk. It exposes the baby to a variety of tastes, and they might be more likely to accept a variety of foods once you get them onto solids. So keep up with the variety of foods. No need to avoid anything spicy or strong tasting if that's what you've been doing all along.
How about drinking? Like we know moms have to drink a lot of water. Does it help with the volumes, or this is just to keep mom hydrated?
This is a good question because you're right. Hydration and fluid, they're pushed on moms. I've seen moms walking around, and you know who you are. You might have been one of these moms. You got like that 4-liter jug of water. You're walking around the unit with that waterlogged look on your face. You're peeing every 20 minutes to keep up your milk supply. And what we actually know is that, yes, it's important to avoid dehydration, absolutely. But it's also important to avoid overhydration because both dehydration and overhydration can decrease your supply. So we aren't prescriptive in our unit. We don't tell moms you have to get a couple liters or 4 liters. We just encourage drink to thirst. So we've got some water coolers around the unit. Moms are welcome to bring in water bottles, and we say, if you're thirsty, have something to drink, but don't feel like you have to drink a lot of fluid to increase your supply. Mm-hmm. People often forget too, in the food that we eat, there's a lot of water in there. Fruits, vegetables, even meat actually has quite a bit of water in there too. So no need to waterlog yourself. It's just going to make you pee more often and not increase your breast milk volume.
Okay. How about caffeine? Because caffeine, we also talk about that, and we know our babies always take every day when they're a little shot of espresso. They
have like 10 espressos a day already. So, and you know what? Caffeine is absolutely okay. I remember one family, the mom had been avoiding, she always had a latte. Starbucks latte was her thing, caramel macchiato, and their baby was in here, and she was very cautious of, you know, what she was doing. She wanted to have the most perfect healthy diet. And the one morning she came in, she was exhausted. They had another kiddo at home. It's long days in the NICU. It's sleepless nights. She said, I just need a latte. I'm like, have a latte, have two. Absolutely. The parents don't need to avoid caffeine. General guidelines will say, you know, up to 2 cups of coffee, maybe 4 to 5 cups of a black tea. And probably even having a little bit more than that. Honestly, the research isn't that great around it, but no need to avoid it when your baby's in the NICU and you're providing your own milk. because like you said, they're getting a shot of espresso a couple times a day anyway.
Well, that's what my question. Somebody said, "Oh, he has a shot of caffeine." I said, "What do you mean caffeine?" Hey, your son has a little espresso every day in the morning. Oh, all these things that we learn in the NICU with our babies.
Yeah, for sure.
Let's talk a little bit about donor human milk, because I know you're very involved with the NorthernStar Human Milk Bank in Regina. So how can parents access donor human milk bank at this time? And is it safe for parents who want to keep donating to milk banks during the pandemic?
Mhm. So Canada actually has 4 accredited human milk banks. There's one in BC, NorthernStar Mother's Milk Bank in Calgary. There's a public Mother's Milk Bank in Quebec that's affiliated with Hema Quebec, and then of course in Ontario, the Rogers Hickson Bank. And you had Dr. Unger on one of your podcasts not that long ago, and she was talking about the importance of donor human milk and milk banking, and a little bit in light of COVID as well. In Saskatchewan, we use NorthernStar Mother's Milk Bank. And right now it's available to all of our NICUs, so the NICUs in Regina, Saskatoon, and Prince Albert. And I would venture a guess that 95% of NICUs in Canada have a standard of using donor human milk in their NICU and buying it from different places. Toronto, BC, Quebec, they triage to their own locale, but NorthernStar is a bit unique in that they're considered a community milk bank. So any NICU or PEDS unit or mother-baby units can access it. Any family across Canada can access milk from NorthernStar. In hospital, in the NICUs, we have specific criteria which babies can access it. We have a couple of our mother-baby units, the one in Yorkton and one in Moose Jaw, who access it with specific criteria. Families can access it as well. To get it from NorthernStar, you need a prescription from a physician, a nurse practitioner, or a midwife, and then that prescription goes up to Calgary. And they do a little triaging because they want to make sure that there's enough milk to go to the NICU babies because they're the most fragile and sick. And they always have enough. There are so many donors across Canada. It's amazing. So they always have enough. It can be a bit cost prohibitive. So sometimes insurance companies will cover the cost. Calgary does have a compassionate care program, but I believe that might just be for folks in Alberta. But families can access it if their baby is in the NICU in the community with a prescription.
So if families want more information on the milk banks in Canada, we do have that information on our website. They can just go to each website and get information from their region.
Yeah.
But Natalie, when we were talking before, you mentioned informal milk sharing. Is this a common practice? Because I don't know much about that in Canada. I'm from Brazil, and I know Brazil is something common, but I didn't know it was something common in here in this country. Or can you tell us about it?
Informal milk sharing. So that term you might have heard peer-to-peer milk sharing. I mean, that's really a 21st century definition of it, but really wet nursing is a type of informal milk sharing. That's been happening since babies have been born. And it certainly does happen. It happens in Canada. It happens in our NICUs. Quite a few years ago, before NorthernStar Mother's Milk Bank was available, there was a group out of Saskatoon that actually put out a proposal to our Saskatchewan government to establish a milk bank in Saskatchewan. And they had actually surveyed NICU parents to get a feel what their thoughts would be on accessing using donor human milk in the NICU. And there were a couple of respondents who shared that they had actually got milk informally from friends and pass it off as their own in the NICU. So we know what's happening. We tell parents that breast milk is so important for the health and development, but then there are situations where maybe a lactating parent doesn't have enough volume, maybe breastfeeding or providing breast milk is contraindicated for various reasons. Maybe it's an adoptive set of parents. There's lots of reasons where people can't get access to it. And buying it, until recently, they couldn't buy it anywhere, from an accredited milk bank. And even if there was a milk bank now, it can be cost prohibitive. So it makes sense that families are turning to alternatives using what we call informal milk sharing. So there's different ways that can look. So you can get extra milk from a trusted family member, a dear friend, an acquaintance, a complete stranger. So it's happening online. There are groups, some good examples are Human Milk for Human Babies, Eats on Feet. They have Facebook pages and local chapters where they match up people who have excess milk with people who need milk to share their milk. I mean, they have some sort of unwritten rules. They expect folks in their community to be really open and honest about their lifestyle, about health issues, because there are risks with using unpasteurized donor human milk. There have been some studies where people have looked at the bacterial load, the viral load of breast milk purchased online, which, by the way, it's illegal to buy donor human milk in Canada unless it is from an accredited milk bank, but people still sell it online. And what they found was milk that was purchased online often had high bacterial loads, high viral loads. It was adulterated or diluted with cow's milk or water. It had high levels of over-the-counter medications, even illicit drugs. So that's why it's so important that we talk to families about it. We can't have our heads in the sand. We know what's happening, but we have to provide them with information so they can make the safest choice that's possible. Now, as a health authority, we've taken the stance really that we don't recommend it for safety reasons, but let's talk about it. Let's talk about what's the safe, if you're going to do this, what's the safest way to do it? And BC Perinatal Services, you might even have their information on your website, but they've got really great resources on informal milk sharing for both healthcare professionals and families. It explains it really well. It talks about the different safety concerns. So certainly using milk from a trusted family member, a trusted friend, implicitly, right, you would assume would be a little bit safer than buying from a stranger online.
But definitely talk to the healthcare professionals in the NICU, because NICU babies are more at risk. We always have to look at their safety first.
Absolutely. And because majority of the NICUs can access pasteurized donor human milk, so that means the milk is tested, comes from tested donors who have been screened, and then it's pasteurized to kill any pathogens, viruses, bacteria. We know it's a safe milk to give the preemie babies.
Absolutely. Natalie, one last message for the parents watching us here today that are still in the NICU or maybe at first year at home with their babies.
All the best to the parents. You've got this. This is unexpected, but you have a whole healthcare team to help you through this. Ask questions. Don't be shy. No question is a bad question. Reach out to your support groups. Reach out to organizations like the Canadian Preterm Baby Foundation. They have a lot of resources that support parents. You're not alone. We're here for you. You need but ask.
Oh, thank you, Natalie. Thank you so much for joining us here today.
Thanks for having me.
And thank you everyone for watching us here today. As I mentioned before, we are running Facebook Live twice a week, Monday and Fridays, 1 p.m. Eastern time. And if you have a topic that you are interested in learning more about, just send us a message. I'll be happy to find the resource for you. All the past sessions have been recorded and they are available on our website on canadianpreemies.org. And on Wednesdays, 1 p.m. Eastern time, Kate Robson, who is a therapist and also a mother of 2 premature girls, is hosting real-time peer support groups. And to access her group, you can join the Canadian Preemie Parent Support Network, which is our private Facebook group. And we also have a new program to support families. It's the COVID care program. You have more information on our website. Families across Canada with a baby in the ICU or first year at home can access a 2-session of therapy online with therapists from across the country to give you strategies and resources during this pandemic. So you can access, because we are very concerned about parents and mental health, and we know we need support, and we are here for you. You can get more information also on our website, canadianpreemies.org. So thank you, and I see you next time.